Hi, everyone. Welcome to the Tufts University USDA Human Nutrition Research Center on Aging Monday seminar. This is our first seminar of 2025, and we're glad you're able to join us. We are honored and grateful to have as our speaker today Dr. John Batsis. Dr. Batsis is an associate professor of medicine at the University of North Carolina, Chapel Hill in the Division of Geriatric Medicine. He also has a joint appointment in the Department of Nutrition. He is an accomplished physician scientist, and his research primarily focuses on understanding the interplay between body skeletal muscle mass and adipose tissue in older adults. And he's going to talk to us today about body composition changes with weight loss among older adults with obesity. And with that, I'll turn it over to you, John. Thank you very much.
That's great. Well, thank you very much, Kyla, for the kind introduction, and thank you very much for the opportunity to speak to everybody today. This is a topic that I love dear to my heart, so hopefully you can do it justice today. And I always like to say, since it's still January, Happy New Year to all. Some fundings and disclosures here. So I'm a clinician at heart, and I always like to say that my clinical work informs my research, and my research then backtracks to my clinical work. And really, some glimpses from the front line, which really kind of inform how I think about things from a research perspective. Older adults want to preserve their health, and they really worry about their physical function and their quality of life. And when I think about when I see a patient in front of me in my clinical practice, is independence is of critical importance. They don't want to land in a nursing home. That's really at the end of the day. And they're less worried about, death really, as they age. Which I always find really kind of interesting. But they really want to be mobile. They want to be able to do things that are really important to them at the stage of life. So I'm talking about obesity, and I'm not going to delve into the epidemiology of it. I'm sure this audience is very familiar with it. But what I do want to focus is that we know that obesity trends over the last 4 or 5 decades of life in the United States have increased, and then we've used body mass index, which again has its issues. New Lancet Commission has come up as well, which I will not talk about today. Still delving into their discussion and their findings. But this is an interesting study that came out just a couple of weeks ago, which demonstrated some changes in adult obesity trends, which you see by BMI, by body mass index, over the course of the last 10 decade or so in life. And you see, even in older adults, this is the purple and the blue, the light blue here, older adults, that the trends actually rose, but then slightly dipped. And this is unlikely to be due to the new obesity medicines, but likely thought to be due based on some COVID-related mortality. So just something to be mindful of when you look at the data. You need to be thinking about what's going on from a population-based standpoint. But for all in all, that the trends are still, it's still a big population public health based problem here in the United States. Okay, let's dive into here. The so what? I always like to ask why should we care about this? And we should care about this because we know that there are changes and age-related changes in body composition with age. We know that as one ages, that there is a redistribution and an increase in fat as one ages, and redistribution to the more visceral areas. And we know that there's age-related declines in both muscle mass and reductions in muscle strength. And this is the term sarcopenia, which coined back in the late 80s at Tufts, and now being refined, and I'll kind of get to that, reduction in age-related reductions in muscle mass and muscle strength. There is an interplay between metabolically active muscle and metabolically active adipose tissue. And you can see that this interrelation, when you gain fat and you lose muscle, these are age-related changes, can lead to metabolic disturbances. This leads to increases in insulin resistance, increases risk of type 2 diabetes and reductions in beta cell function, leads to inflammatory responses, lipotoxicity, fatty acid oxidation. And then as a result, with aging, you have reductions in muscle protein synthesis. So you not only synthesize less protein, but you actually increase your degradation process. And this creates a whole challenging process, which I'll show you a very complex diagram coming up right here. And this is something that myself and Dennis Villarreal, a colleague of mine at Baylor, actually put together, which really interplays the concepts of sarcopenia and obesity, and really the crosstalk between adipose tissue and muscle tissue. And it's complex. I'm not going to do a deep dive here, but what I want to kind of emphasize to folks here is that there's a lot going on at the cellular level that we A, understand, and B, don't understand. But there are a lot of external and internal influences that lead to this crosstalk, and that then subsequently can lead to phenotypic changes that end up leading to functional decline, frailty, and disability. And this is a lot of the work that I had done earlier in my career, was really looking at many of these associations. And I recognize and I want to acknowledge that the definitions of obesity and with sarcopenia, sarcopenic obesity, have evolved over time. But what we know is that when you look at these associations, and a number of them with different data sets as well, there's a strong association of the sum of the parts is greater than the whole. So having obesity, a person with obesity is at increased risk of functional limitations, falls, mortality, reduction in quality of life, and potentially increased risk of cognitive impairment. The same goes with sarcopenia. But you put two and two, you put both of these together, there's a synergy. And what we know is that you can get ectopic fat deposition. And this is, I always feel a picture's a thousand words. And as a result of some of the biological changes that occur in muscle, you get fatty deposition in muscle. And this is a cross-sectional image of one's quadricep muscle. As you can see on the left, you have hyperintense deposition on a cross-sectional image of an MRI. And you can see here, this hyperintensity is fat within the muscle tissue in a person with obesity, whereas here, there's no fat deposition. And again, this is really important. This is really a hallmark of a person with sarcopenic obesity. I do want to bring to your attention that these definitions of sarcopenia and sarcopenic obesity are evolving. And I share this because one of the challenges in the literature in the past and going forward has been trying to standardize these definitions. And it's really important when we think about weight loss interventions, because we've been throwing the term out, weight loss induced sarcopenia. And what do we mean by the term sarcopenia? And really, nowadays, when we talk about the term sarcopenia, we need to be thinking about loss of muscle mass and strength. Muscle performance is now considered an outcome measure. And that's really important. This is the Global Leadership Initiative in Sarcopenia, which I'm privileged to be part of. And we're trying to crystallize this terminology and getting away that sarcopenia is just muscle mass. And again, I'm not going to go through this entire slide, but just I bring to your attention these two really important citations. And then alongside this, the European Association for Study of Obesity and European Society for Parenteral Nutrition have come up with some screening guidelines and definitions for sarcopenic obesity. And these are clinical diagnoses for screening and diagnosis for diagnosing sarcopenic obesity. So we are getting there. We're not quite there yet, but these are really important. And these can be applied both in epidemiological studies, but also in clinical trials. And I think that's really important. And as you'll see, I'm going to be pivoting now to what I think most of you are really here for me to talk about when we're starting to talk about weight loss interventions. And before I start jumping into what's topical these days, which, as you know, is I'm going to be talking a lot about the GLP-1s and GLP-1 GIPs, these new incretin mimetic medications. I think we need to take a step back. And when we need to take a step back and talk about the traditional behavioral lifestyle interventions. I feel that this is one of the earlier lifestyle-based interventions that Dennis Villarreal conducted, which demonstrated it was a randomized clinical trial of 4 arms. Of a control arm, the other 3 arms had a caloric restriction coupled with either aerobic resistance or combined aerobic and resistance arm. And what his group found was that the arms that had caloric restriction all lost weight. However, those with combined aerobic and resistant had synergistic improvements in physical performance tests, which was his primary outcome, more so than either resistance training plus diet or aerobic training. And I want you to remember this because I'm going to show in a number of slides downstream the importance of unimodal weight loss interventions versus multimodal interventions when we talk about weight loss interventions coupled with medications as well. We took this one step further and we did this remotely. And this is, I'm proud to say that we did this prior to the pandemic, prior to when telemedicine was kind of par for the course. And we did this in a rural weight loss center up in New Hampshire when I was on faculty up at Dartmouth. And we found very similar results. We found a clinically significant weight loss. We found improvements in sit-to-stand 6-minute walk and late life function disability. We also found non-significant reductions, no differences in appendicular lean mass. We found and reductions in body fat and visceral fat. So we found improvements in body composition. There are also some data that demonstrates with behavioral weight loss of improvements of physical function with protein intake. And this is a study that my colleague Katie Starr had conducted, a 6-month intervention. And then we had conducted a 3-month intervention with protein supplementation versus no protein supplementation. What is important to note is when you're supplementing in a behavioral weight loss intervention, you're actually with protein, you're actually supplementing and giving calories. So it's important when you're providing calories, but you're trying to also restrict in a behavioral weight loss intervention, it actually becomes a little bit tricky. So you may not achieve the same amount of weight loss. So here's the challenge. Is all weight loss the same? So many of the trials, many of the primary outcome measures, we talk about weight. Trying to achieve 5 to 10% weight loss in behavioral weight loss trials or lifestyle-based weight loss. We're trying to achieve higher amounts of weight loss with the obesity medications. But when we think about weight, we need to be thinking about what do we mean about loss of weight. This is a very crude diagram. Not the best artisan here, but when we think about weight, we think about fat mass, which we're trying to reduce, and fat-free mass, which consists of muscle, bone, body water, and viscera, amongst other things. So what you're trying to do is you're trying to reduce the amount of fat mass and try to minimize the amount of loss of fat-free mass. And that becomes an issue because it's the balance of the two. So terminology is extremely important. And Steve Heimsfeld at Pennington and his group have really done a great service to the field by really hammering home the importance of terminology. This article published in 2024, and there's another recent one, has really explained the importance of using the right terminology. I'll be guilty in saying that I've used incorrect terminology myself, and I probably still do, but it's trying to getting into the pattern of using the right terminology based on the device and that one is using to measure body composition. So when you're looking at fat-free mass, for instance, fat-free mass consists of, as I mentioned, skeletal muscle mass and water, protein, and viscera. So you want to be able to be mindful of that because you can't equate fat-free mass to muscle. And that is often used interchangeably. For instance, if you're measuring DEXA, we often you say, well, you're losing muscle when, the DEXA shows that you're losing X amount of muscle using DEXA. Well, you're losing lean soft tissue mass, but you're not losing muscle mass. So it's extremely important. And that's really important because you have changes in resting energy expenditure. And you can see some numbers here that I've been able to find with reductions in resting energy expenditure for loss of fat with loss of muscle. So you have reductions based on the amount of fat or muscle that is lost. This is one of my favorite slides that I've come up with. This is probably the best graphic that I will probably ever come up with, but I want to walk you through this. And this is from a conceptual model standpoint. So I'm thinking about this clinically. We know that one gains weight. If one gains weight, they develop obesity-related complications. And then as one gains weight during the life course as an older adult, they have an increased risk for developing functional decline. So their physical function decreases. They lose weight if a patient, participant, whatever you want to call them, if they engage in a weight loss study and they lose weight, they reduce their risk of obesity-related complications. And we've seen that with behavioral weight loss. We also know that they lose fat loss, but we also know that when you lose weight, you lose both fat and you lose muscle. But when you lose too much weight, you can lose too much muscle. And that's what you want to try to avoid. And we don't know what that optimal range of fat and muscle loss is. And that becomes a major issue when you try to push the degree of weight loss. And this is where the unknown strikes. We know we have data, and I'm going to show you some data on some of the body composition changes that we see. But when you push the envelope too much, what happens? What happens to physical function? What happens to body composition? So let's start off with look ahead. Look ahead compared an intensive lifestyle intervention with a control. And we know that over 8 years, both groups over 8 years actually gained fat mass and lost lean mass. If you recall, I asked you to remember the Villarreal study. So in the Villarreal study, the group that had the combination diet, exercise, diet, aerobic resistance exercise had the highest amount and synergistic improvements in physical performance. But you look at the amount of lean mass lost using DEXA. They use DEXA to measure lean mass. They still lost a significant change from baseline. Resistant exercise mitigated that loss, and aerobic really did not. They had a significant loss. Strength was a little bit different. Resistant exercise actually improved muscle strength. There was minimal difference between the combination and resistance, but aerobic actually had minimal impact on strength. So this was almost one of the first studies in an older adult population with obesity that underwent a weight loss intervention. This is important to note. This was a population with a diagnosis of frailty that a caloric restriction in combination with aerobic and resistance training actually led to improvements not only in objective physical performance based on the physical performance test, but improvements in strength, but also led to losses of lean mass categorized, defined by these study authors in their study. Aerobic activity led to significant losses in DEXA-based lean mass and did not lead to improvements in muscle strength. It's really important to be mindful of that. So what about changes in intramuscular adipose tissue? And this is data from the longitudinal health ABC study. So over a 5-year period, they assessed serial CT imaging. And what they found in both men and women, that individuals who that gained intramuscular adipose tissue were higher in those who had weight stability or weight gain than those who had lost weight intentionally. So if you had lost weight, the progression of so everybody gained IMAT, but if you had engaged in intentional weight loss, you gained less than those who had actually been weight stable or had weight gain. So, and we know that intramuscular adipose tissue is a driver for that complex diagram that I had showed you earlier. Okay, so individuals stop their weight loss, their active weight loss. Then what? Then what happens? So Kristen Beavers actually conducted this study after their weight loss intervention in postmenopausal women. After a 5-month RCT, she looked to see their body composition subsequent to their RCT. And what she found was that for every 1 kilogram of fat lost during the weight loss effort, 0.26 kilograms of lean mass was lost using DEXA. However, for every 1 kilogram of fat regained in the following year, only 0.12 kilogram of lean mass was regained. So which says to us, after behavioral weight loss intervention, the regain of weight that one gets after in the weight regain period is more fat than muscle slash lean soft tissue. So that's again a problem, and I want you to think about that when we think about, if someone ends up going on, for instance, a medication and needs to kind of needs to stop it. I'm going to present to you some data here, some systematic reviews. Again, looking at the impact of protein intake and lean mass. This is a meta-analysis of 20 studies, which favored protein supplementation during weight loss efforts in older adults losing weight, which it showed it was favorable. And resistance training, which again was shown in Villarreal's study. But it was very interesting and not surprising that there's a significant heterogeneity in the outcomes. And this is actually was seen, there was there's heterogeneity in the type of resistance, the type of exercise, the duration, the types of patients enrolled, the variation in the response, the compliance. So there's a lot that we have to learn about all these factors and all these variables to help individualize the right person to the right exercise to make sure to optimize efforts. Okay. So before I pivot to the medications, I want to share with you what happens with profound weight loss. And our model really is that of bariatric surgery. So you can see here that laparoscopic Roux-en-Y gastric bypass, you have a significant amount of weight loss of weight of 34 kilograms in this one meta-analysis, with a lean mass loss of almost just over half of it, 18.1 kilograms. So 53.2% was lean mass. In sleeve gastrectomy, 44.1%. So there's a significant amount of the relative amount of weight loss was lean mass. So time to pivot to medications. Here's the thing that I worry about. I'm very excited about the obesity medications, and I'm not using the word anti-obesity. The terminology continues to evolve, but I'm using the term obesity medications. That's what the terminology that Obesity Society is now currently using and recommending. But these are some of the FDA-approved medications for use in older adults, known to many of you, predominantly the semaglutide and tirzepatide. What I do want to bring to your attention is that the majority, if not all, these medications were the number of older adults enrolled in these trials are low. Until recently, until the heart failure trials that were conducted in the semaglutide, tirzepatide, very, very few had a mean age of 65. None were conducted specifically in older adults. So you're extrapolating data from trials that were conducted predominantly in younger adults. So it's really important. And a recent systematic review that was just published in Obesity in the journal noted statistically significant weight reduction between intervention and placebo across all types of obesity medications in older adults. It looks like the efficacy of weight loss looks very similar, and related to older adults, few reported on adverse events, but I want to show you a few slides on this. So when you do a drill down, and I've done a bit of a drill down here, the number of trials, that report those over the age of 75 are almost non-existent as well. So we're using data on younger populations to those in older populations. So we need to be very cautious because of multimorbidity, frailty, and other variables. And biologically, they're very different populations. Just to kind of get everybody on the same page. Semaglutide, tirzepatide. Semaglutide is a glucagon-like peptide 1 receptor agonist. Tirzepatide is a GLP-1 and GIP dual agonist as well. Both are available currently in older adults. They are available for persons with diabetes, type 2 diabetes. They are not covered by Medicare for weight management. But what I would like to highlight here, the weight loss occurs, mean weight loss in efficacy-based trials is between 15 and 25%. Nadir weight loss occurs around 52 to 68 weeks on average with both medications. You stop the drug. If you stop the drug, you will regain weight, but generally the weight regain with both of these types of medications, you actually don't go back up to your baseline. You still have reached your about 5% weight loss. Keep in mind that these are efficacy-based trials. They do couple with a behavioral intervention of lifestyle, which includes regular dietitian visits and exercise as well. And these formative efficacy-based trials were in younger populations as well. How about in older adults? So these medications were initially evaluated in persons with diabetes and looking at A1C, hemoglobin A1C. This study here looked at differences between younger and older and actually found that the outcomes were slightly less favorable than in younger individuals, but not dose dependent. This is for tirzepatide. That said, I have found other studies that have shown efficacy has been the same. So I think the jury is still a little bit out as to whether or not efficacy-based outcomes are about the same. For instance, these are the SUSTAIN trials, which looked at semaglutide and a comparator. When you looked at the SUSTAIN trials, and keep in mind the comparator is different depending on which SUSTAIN trial you used. Based on weight loss, this is weight loss. The weight loss appeared to be very similar depending if you were an older adult versus a younger adult. So it's extremely important to be mindful. So from a weight loss standpoint, it appeared to be very similar. I do want to highlight these these trial here. This is a semaglutide in heart failure with preserved ejection fraction. And I want to highlight this trial because this is one of the trials that actually had a mean age over 65 years old. These are older adults with heart failure, a 52-week base trial. A couple of things I want to bring to your attention. One, the change in weight that was observed here is much less than seen in the efficacy-based trials that I showed you previously. If you look here, it's almost, the estimated treatment difference is about 6.4%, much less than the 15 to 25% that are seen in the other efficacy-based trials. The other point here is they evaluated a co-primary outcome of the Kansas City Cardiomyopathy and Clinical Care Questionnaire. It's a quality of life questionnaire that is seen. And it was impressive in the sense that they demonstrated a 7.3 point difference with a minimal clinically important difference of 4 to 5 points. So it achieved what it wanted to achieve. Objectively, they measured 6-minute walk test. It was statistically significant. Very wide confidence intervals, 14.3 meters. In my mind, that is not hugely clinically significant. So, and this is the other thing to be mindful of, is that you want to be mindful of statistical versus clinical significance here. So it's nice, it's fine, but it's something I think you want to be mindful of some of the results of these. And very similar results were seen with tirzepatide as well. How about cardiovascular outcomes? And I share this here because when you look at the outcomes in older adults, the outcomes in older adults actually demonstrate the adjusted hazard ratios are actually less robust the older you get. And you can see the upper range of normal is 75 here. And this is in Medicare beneficiaries. So it's unclear using this data set what transpires in 75 up. However, this was a retrospective review just published this past year that included semaglutide and tirzepatide. What I want to bring to your attention here is the table at the bottom. While there was an 8% reduction in risk reduction in any cardiovascular event, when you compare to individuals between the ages of 65 and 70 as a referent, it appeared that those over the age of 80 had a higher cardiovascular risk, than those compared to those from the age group of 65 to 70. So you want to be mindful here. Do you need more data? Is it the right population? We don't know what this, where we're heading here with some of these medications. Let's skip that. How about adverse events? Adverse events are likely dose dependent, particularly in older adults. And this is a really important, I think, sub-study of tirzepatide, which showed discontinuation rates. And there was a recent study that actually just came out in I think it was in JAMA Network. I didn't have a chance to put a slide in, which showed discontinuation rates were actually age dependent as well. So something to be mindful of. I'm gonna, just for the interest of time, kind of scoot along here. Okay. So this next part of my talk is really kind of, shifting here and talking a little bit about these GLP-1s and body composition. Here's the good, the bad, the ugly. The bad is that we don't have a lot of data. And when we think about what data we have, a lot of the data that we have is A, old, and B, minimal. So liraglutide is one of the older or second generation GLP-1s. And this study was conducted in younger patients, a 10-month study, and actually demonstrated that using DEXA, that 23% of the total weight loss was lean soft tissue loss. So when you fat-free mass lost was 23% of it. But here's really where the meat of this talk is, and this is really where I want to hone in and spend some time, is the sub-studies of both tirzepatide and semaglutide and tirzepatide. The data of DEXA, there were some sub-studies that were conducted, and they were present. You know, you had to dig it a little bit. The data was conducted in a sub-study of individuals. Keep in mind that these are not older adults, and I think that's really important to be mindful of. So when you look at the amount of change in fat mass with semaglutide, 8.36% kilogram versus placebo. Estimated treatment difference is almost 7 kilograms of fat loss, 0.27 kilograms of visceral fat. And lean body mass based on using DEXA was 3.43 kilogram. So that's a good bit. And then comparing tirzepatide, this was using bod pod. It was less. So sorry, back here, 40% of the weight loss was lean body mass. That's much more than what we think about. We think about when you lose weight, about 25 to 30% has been suggested to be lean body mass. So it's a little higher based on this ratio. Using bod pod, which is air displacement plethysmography, the percentages were actually lower. And this is consistent. I didn't put all the studies here, but this seems to be consistent depending on the modality you use. Bod pod, bioelectrical impedance analysis, or if you use DEXA, you're going to get different numbers depending on which modality you use. So you need to be very cautious about that. This is a study this is a paper which I strongly recommend you read if you have interest in, by Locatelli. And I thought that they really did justice in terms of really doing a deep dive, and the schematic really highlights the concerns, in particularly amongst older adults. So I'm going to walk you through here. So they use that with Wilding's data, the SURMOUNT-1 DEXA data, noting that 6% of participants were over the age of 65. And you can see here, they present the data, both relative change and absolute change. And that we don't know which way should we report the data. Should we report, is it better to say, well, our relative body composition is better, or are we more worried about absolute changes in our body composition? We don't know. We don't know which is the better way to report, and we don't know which is better associated with different long-term outcomes. So in my mind, in my opinion, you need to present both. So fat mass, you can see there's a 7.4% decline. And in corollary, when you lose fat, you're going to gain lean. So because you have to, your 100% has to maintain at 100%. So relatively, you start off at 48.2% of fat, 51.8% of lean mass, but your ratio improves. Now, absolute change, your weight went from 104.8 kilograms, you lost 23 kilograms, you're down to 81.8. But your lean mass dropped by 6 kilograms, your fat mass dropped by 17 kilograms. And I think this is the point that these authors wanted to make. 6 kilograms of lean body mass loss amounts on average to 10 years of skeletal muscle aging when you look at the larger picture. So you're basically recognizing that persons with obesity have larger amounts of skeletal muscle mass because they need a larger body weight and the like. They still knock off approximately 10 years of skeletal muscle aging. We do not know what the implications of that is. both functionally and biologically. In addition, we don't have the segmentation of the DEXA. So DEXA, as you know, allows segmentation, arms, legs, and the like. We don't have that data, and whether or not that has implications as well. Where is the participant losing this information or this lean mass? And this is again another body composition trial with tirzepatide in a slightly older population, but actually demonstrated slightly less amount of fat-free mass. It's thought that tirzepatide may have a little bit more favorable changes in fat-free mass, but again, the jury's still out. How about in the real world? I think I mentioned, it's easier to get some other modalities like that, like bioelectrical impedance versus DEXA or other modalities. And then we talked about the proportional of lean mass with, and the discontinuation rates are higher in those over the age of 65. Skip that. Now, what about multiple modalities? And unfortunately, the synergy between exercise and GLP-1s, there are very few studies that have looked at this synergy. This is a really well-designed study by Lundgren's group, published a couple of years ago. But what I want to bring to your attention here is that they did a 3-arm study of liraglutide, exercise, and liraglutide. And what they found is that individuals with liraglutide did lose some weight. Exercise did not lose weight. But exercise seemed to potentiated the loss of weight with liraglutide and led to significantly more weight loss, but actually also led to improvements in lean mass. So there may be something here. Now, keep in mind, this is liraglutide. Liraglutide on a whole leads to 3 to 5% weight loss. So it's not as potent as some of the more novel and newer incretin mimetic medications like semaglutide and tirzepatide, but it's still in the same family. So we want to be mindful that maybe this type of exercise, resistance-based exercise, may be something that we need to think about coupling. We should be coupling with these types of medications. How about physical function? Well, we have self-reported physical function using different measures. And it seems as though self-reported physical function, these are 2 meta-analyses, were very favorable. I will share with you that we have not found objective physical function and performance other than the 6-minute walk test. Certainly, if someone knows of any studies, please do share. But it's something that there's a major gap in the literature. And this is another study that looked at the STEP trials as well, that looked at patient-reported outcome measures, which demonstrated treatment differences that were clinically significant. I'd be remiss not to talk about some of the newer medications that are coming into phase 3 and further trials that are really focusing on muscle. Bimagrumab, this was published, a phase 2 trial published a few years back, which demonstrated not only improvements in reductions in fat mass, but some improvements in lean mass as well. And it appears as though that there may be some impact on physical function, but the jury again is still out. There are others that are still that are being evaluated as well, and we need more data on that. Enobosarm is another medication which may have an impact on muscle and function. This was used in the past with patients with cancer, with cancer cachexia. This was without patients with obesity, but it's been shown in early phase trials, improvements in stair power and improvements in lean mass. So again, I think there's an appetite for these, particularly with some of the newer incretin mimetic medications. Be aware the number of new obesity medications is dizzying. These are the ones that are in the pipelines in phase 1, 2, and 3 and are currently on the market. These are the ones that I've written down here that are probably a bit more familiar, that you may hear from sooner than later. I know a few of you in the audience here that my love for geroscience and kind of thinking about the biological mechanisms, and I think we need to think about these when it comes to medications and why some individuals do well and others don't, not only from a clinical outcome standpoint, but why we need to understand why our individuals may be losing fat or not losing muscle, and others are. So we need to be thinking about these and thinking about these targets. And I know some folks at some of the institutions that are on are thinking about this in great detail. And we need to be, really evaluating some of these blood-based biomarkers as well. And then really relying on precision medicine and data-driven approaches to the right treatment for the right person at the right time, because some people will have improvement in outcomes, other people will have worsening of outcomes, and you really want to be able to identify the right person for the right intervention at the right time, and just kind of giving a prescription and off they go is not the right modality. So before I conclude here, here's my take. Big picture. These medications are important in older adults. And many of you who I've spoken to many, and I think my approach has evolved over time. I prescribe them. I'm cautious when I prescribe them. There is not a one size fits all. It's not, here's your med and off you go. They have potent effects. It's not for everybody, and we need to be mindful of who they are prescribed to. The data that we have there's a paucity of it, and we don't know what an individual's functional trajectory. I give an anecdote that of a patient who started on one, lost a precipitous amount of weight, started falling, and we're wondering why the patient was falling. Came to me for an evaluation, and I'm like, they started on this medication, and then they started falling, realized they had lost 40 pounds, and stopped the medication, weight gained up, became functionally, robust again. So you need to be mindful of this. We don't know if weight loss induced sarcopenia is exacerbated. We don't know if function is improved. We need data. I'm a firm believer that because we have medications doesn't mean lifestyle and behavioral modifications should go out the window. We still need an interprofessional team and a multi-component approach. It does, these medications are not for everybody. There are equity issues, there's no doubt, and we need to be thinking about how do we overcome them. We need to be thinking about long-term consequences. Aerobic and resistant exercise is the norm. Protein supplementation is likely to benefit, and we need to be thinking about creatively how do we monitor body composition and monitoring grip strength and muscle mass. This is a major translation issue. I've had this conversation with many. As a researcher, I understand there are limitations. As a clinician, there are limitations. How do we bridge this gap? There are policy issues here, which I won't get into. And with that, I want to thank all my many collaborators, and I thank you very much for your time today.
Thank you so much, John. That was very interesting. So if you have questions, please go ahead and put those in the Q&A. There's a couple here that I'll start with. The first one is from Larissa Constantino. And she asks, do you distinguish fat-free mass and lean mass? And is the difference between them important to consider?
Yeah, that's a great question. And I think, I would say, if I rewind a number of years, there continues to be confusion, and I'm going to defer to a recent article that, again, Steve Hemsfield, who I feel is, a good mentor and leader in the body composition field. That free mass and skeletal muscle mass, I feel, are kind of almost like the equivalent, and then lean mass, really, in my mind, I feel is kind of a subcompartment of that. And how do you measure the lean mass is kind of the $1 million question. You need to be thinking about what modality are you using, and moving away from the one size fits all. I think that's the key. We can't be using the word muscle unless you're actually measuring muscle. So, for instance, if you're using MRI, you can measure muscle, but you can't measure muscle using DEXA, for instance. I give you that just as a consideration.
Thank you. The second question is from Saidas. She says, thanks for all the great points you discussed. Agree with needing to sort out the issues with relative change in subcomponents of body comp, especially those within fat-free mass. The question we need answered is if the baseline body comp status versus change poses greater risk for weight-related health, especially for sarcopenic obesity in older adults.
Sorry, I'm trying to the baseline body comp status. Yeah, that's a great question, Sai. And it's, I think what you're asking here is like, where are you at the beginning, and are you losing too much during the intervention? And I think they're two different issues, I think. And we don't know. Like, when you think about, I think about it as a clinician. Someone comes into my office from a weight loss standpoint. I'm not doing all these fancy body composition measures to say, where are you at baseline before I initiate a comprehensive, weight loss intervention, versus let's start you on and then look at the delta. We don't have that data to be able to monitor. So the question here, I think the delta, do you monitor on simple measures like physical function? Like, if they're functionally declining, is that the best surrogate? That may be what we have because the only way we're going to be able to measure and monitor is if a policymaker is going to allow us to pay, to kind of allow us to reimburse to be able to do DEXA or, BIA. I know there's advantages, disadvantages to that. We can talk about that another day, but or individuals with sarcopenic obesity, I think at baseline, question is, are those the right people? We don't have that data to be able to say, maybe those patients shouldn't be the ones that are on these medications or not. I would love to say that we have the data, and maybe retrospectively we need to see, how did those people do when they were put on that in real world practice?
Thanks. The next question comes from Shelley Fang, and she wonders, was the heart failure trial conducted using DEXA? Because DEXA could be biased by edema.
Yes, that's my understanding.
Yes.
Yeah.
And then Roger Fielding says, John, very nice overview. One of the challenges is that many objective measures of physical functioning are dependent on body weight, e.g. walking, climbing stairs. So performance tends to improve despite the clear reduction in lean mass with weight loss. But I agree, a loss of 6 kilos in lean mass is a lot.
Mm-hmm.
So that's more of a comment than a question. Thanks, Roger. And the next question is from Sarah Booth. She says, lovely talk. What are the implications for when individuals go off these medications, especially the older population who may experience side effects?
Yeah, and this is the thing. Again, it's a lack of data, and I hate to just keep on going back and saying we need data, we need data, we need data, we need data. So, okay, that aside, I think the best that we can do is extrapolate from our behavioral weight loss studies to say, we know that when individuals stop losing weight and then they regain weight, it's the relative body composition phenotype, or the relative composition of of what exists, is not in their favor. I worry that what is going to occur is it's actually be even more detrimental and less favorable in individuals who stop their medications for whatever reason. Again, we don't have that data to see. Yeah, I think in that study that showed in individuals who stop the medication, it would be great to see what is that DEXA data, and importantly, actually, I would love to see what MR data would at time discontinuation versus like even 6 or 12 months later.
Thank you. And actually, can I take the prerogative and ask a question as well? And this might actually go back to, we don't have enough data, but have any of these, I mean, I know they have DEXA, have any of these trials analyzed bone as an outcome, bone loss, and what is it?
Yeah, so we actually I kind of looked at some of these, not as an outcome. So the majority of these have not, but it's actually, some of these are looking at, bone as almost from a safety standpoint. And my understanding is that some of these are DSMB based outcomes.
Okay. And then Sai has another question. Are older adults who are prescribed obesity meds taking them for weight or for short-term goals like pre-surgery weight loss recommended by physicians to be considered for surgery?
And that's a great question, Sai. And I think about it from two aspects. There's one, I think about the pre-op older adult who is seeing, say, the orthopedic surgeon, who the orthopedic surgeon says you have to have a body mass index of under X, or you need to have preoperative weight loss for me to operate on their knee or hip or what have you. And I've actually had some colleagues that have initiated these meds, but 6-12 months beforehand, just so they can get them under that threshold. Again, it's a coverage issue. So if they don't have type 2 diabetes, they're unlikely going to get that covered unless their commercial insurance is willing to cover it. Or they have Medicaid, like at least in the state of North Carolina, if you have Medicaid, you'll get that covered. But if you're covered under Medicare Part D, unless you have a diagnosis of type 2 diabetes, it's not going to get covered. Preoperative bariatric surgery, there are some centers that try to, if you have a body mass index in the 50 plus range, try to get their body mass index further down with some of these medications, because knowing that could potentially reduce postoperative complications.
Thank you. If there are any other questions, please put them in the Q&A now. If not, I'll ask one more if that's okay. And it's about the adverse events. Were there any age differences in the types of AEs that were reported? I know GI issues are a big one. And I'm kind of thinking about your anecdote about your patient with falls. Are there a different, either in the numbers or the types of AEs that occur in the older adults? Or again, you probably don't have enough data, but any trends or anything like that?
Yeah, I'm not aware. GI and musculoskeletal, I think, traditionally I would say falls, but GI seems to be the numbers 1, 2, and 3 in terms of the type that lead to discontinuation.
Thank you. Well, John, thank you very much. That was very interesting. And it was a great way to kick off our seminars series for 2025. And thank you everyone for joining us.